Welcome back, and we'll now move on to the next segment, which is the second plenary of the day, and we'll be switching our focus back to glycemic control and concentrating on targeting the time in range. To commence the session, may I cordially invite the two moderators, Dr. Dimuthu Muthukuda and Dr. Manilka Sumanatilleke, consultant endocrinologist from Sri Lanka. Over to you, Sayan Madam.
Good morning. So we'll be moving on to the next plenary. It's going to be a very interesting plenary, which is practically relevant and it's going to be at a very timely topic. So we've got a very eminent speaker, Professor Nick Oliver. He is the consultant physician, diabetes and endocrinology from Imperial College Healthcare NHS Trust. So he'll be talking to us on the topic, the quest for glycemic control in diabetes by targeting time in range. So it's my pleasure to invite Professor Nick Oliver to deliver this plenary. Over to you, Nick.
Thank you so much, Dimuthu. Morning, everyone. From a still dark and very cold London. It's lovely to see you. I'm sorry I can't be with you in person. That would have been much preferable to this. So hopefully you can all now see my slides. Perhaps somebody could shout if you can't. So I'm going to talk about time in range and how we might look at time in range in people living with diabetes. And I will hopefully leave time for discussion, and I look forward to that at the end. So very importantly, these are my declarations of interest. I'll leave those there for a couple of seconds for you to read. So you're all very familiar with HbA1c. HbA1c measures glycated hemoglobin, reflects the glucose that is bound to hemoglobin in red cells, and can be measured by a variety of methodologies. But the general principle, as illustrated here on the left, is that hemoglobin is eluted in an electrophoretic process, and the peak of HbA1c is measured and expressed relative to HbA, either as a percentage or as millimoles of HbA1c per moles of HbA. We're all very familiar with using HbA1c, and it has a huge evidence base that tells us that it is robustly associated with important micro and macrovascular outcomes and with hypoglycemia. So these are data from the DCCT, the Diabetes Control and Complications trial in people with type 1 diabetes, that proved for the very first time in type 1 diabetes unequivocally that intensive treatment can reduce risk by reducing HbA1c. And on the left here, we have HbA1c on the x-axis, and relative risk of retinopathy, nephropathy, neuropathy, and microalbuminuria. And on the right, we have the relative risk of severe hypoglycemia, again against HbA1c on the x-axis. And as you all know very well, the higher the HbA1c, the higher the risk of microvascular complications. But as we intensify HbA1c, the higher the risk of severe hypoglycemia. So HbA1c is very well established as a marker of risk in all people with diabetes, and not only is it used in monitoring and for intensification purposes, but it's also well validated now for diagnosis of diabetes. These are the data shown in the WHO Guide for Diagnosis of Diabetes from 2011. And they show very nicely that for fasting plasma glucose, 2-hour plasma glucose on a glucose tolerance test, and for HbA1c, there is no risk of retinopathy until we reach this point here, where there is a takeoff and that's a sudden increase, and that coincides with a fasting glucose of 7, a 2-hour glucose of 11, and an HbA1c of 6.5, and it's those cutoffs that we use for diagnosis of diabetes. So HbA1c is an international standard. Very importantly, it's aligned to a reference standard in all laboratories. So an HbA1c measured here in London today will be the same as an HbA1c measured in Sri Lanka or India today. There is quality assurance and quality control, which means that the standard doesn't change and it's internationally available and everyone is familiar with it because it's been ubiquitous in clinical studies and in clinical practice now for over 3 decades. It's applicable for diagnosis, monitoring and risk stratification, so it's a fantastic biomarker for people living with diabetes. But of course it does have limitations. In some circumstances it can be inappropriately low. In some, it will be inappropriately high, and some things have variable effects on it. And again, you'll all be very familiar with these limitations to HbA1c, and I won't go through the whole table. The other limitations for HbA1c are that it is expensive, relatively. In the UK, it costs over £5 for an HbA1c. And while in terms of monitoring, that might be seen to be good value if we're only doing it once or twice a year, it's still an important cost to bear in mind. It requires 120 days to stabilise, and it needs access to a laboratory with appropriate quality assurance, quality control, and machinery. Also, and this has been said very frequently, HbA1c is said to not capture hypoglycemia or glucose variability. And I'll come back to that statement because it's very important when we think about times in ranges. So what is time in range? These are 3 different glucose profiles, but they all tell us the same thing for HbA1c. So for each of these profiles, on the left, a very variable profile with lots of time that's of higher glucose and lots of time with lower glucose, an intermediate glucose profile and a very flat glucose profile, but they all have the same. They all have an HbA1c of 53 millimoles per mole or 7.0%. But you can see that these are very different qualitatively for the person living with those profiles. This person has high glucose and hypoglycemia. This person has some high glucose and occasional hypoglycemia, and this person is spending 100% time in range. So times in ranges, and I'll talk about time in range, which is the time between these 2 green lines. And I'll talk about times in ranges as a general description for all of the time above, time within, and time below. So you can see that the times in ranges for these 3 different profiles are very different, while the HbA1c is the same. And it's this principle that means that time in range may be useful for people living with diabetes and for us as healthcare professionals. So here's a little bit more detail of what we're looking at. So we have a target range here, which is generally 3.9 to 10 millimoles per litre or 70 to 180 milligrams per deciliter. We'll have those time below, so these hypoglycemic times, and we'll have time above range for hyperglycemia. So there's really only 3 ranges we need to think about: above, within, and below. And I'll come back to the most important numbers for those a little bit later. We can measure time in range either by finger sticks, by self-monitored blood glucose, so these green dots, but that may miss some of the time below range, for example. So if we just use the self-monitored blood glucose here, we would miss the time below range. Or we can use continuous glucose monitoring readings from either a flash device like the Freestyle Libre or a true continuous glucose monitor like a Dexcom device. I'll come back to those again in terms of how we interpret those. So when we talk about times and ranges, they're expressed in one of 2 different ways generally. So they're either expressed as minutes per day or percentage time. So if we think about percentage time in range, in general, we're aiming for over 50% time in range, and each 1% there is approximately 14 minutes of your day. So if we say that somebody spends 2% of the time in hypoglycemia, that means on average they'll spend 28 minutes per day with a value below target. And it's because that's so understandable to people with diabetes that times in ranges are attractive. There's, as you will all know from history, there has been a long confusion between HbA1c values and glucose. So if we tell someone their HbA1c is 7.5, they equate that to a glucose of 7.5. And while they may not be terribly different, They are very different numbers and they mean different things, whereas times in ranges are very much more understandable because it's very easy. If you say to someone, you're spending 1 hour a day above your target, let's think about when that is and how we help you. Because we're looking at time in range, we can use a very short duration of data. So we could report time in range for one single day, and that's much more attractive than waiting 120 days for an HbA1c. And because we're using routine measurement of glucose either by finger prick or by continuous glucose data, they're a part of usual care, so hopefully represent a lower cost. They're independent of the laboratory, and I promise this is the only time I'll mention it. They're also pandemic proof, which has been very important for us over the last year or so, because we've been able to look at people's times in ranges remotely and help them to intensify glucose without seeing people face to face in clinic. So that's a very useful additional benefit that I perhaps wouldn't have put on my slides a year ago. So, as I said, we can measure time in range using self-monitored blood glucose. And here's a slightly more detailed view of that for a given day where someone does 6 finger pricks. And you can see that 3 out of those 6 are in range. So this person has 50% time in range. 2 out of the 6 are above range. So they spend 33% of their time above range. And 1 of those values is below, so they spend 16% below target. And it's that simple for time in range with self-monitored blood glucose. It's simply the number of values within each range over the total. So what's the evidence base for using time in range? Well, these are data again from the DCCT that have been reanalyzed. So as part of the DCCT, all of the participants did 7-point glucose profiles. Those 7 points were before and after each meal and at bedtime. So before and after breakfast, lunch and dinner gave us 6 values, and then 1 at bedtime gives us a 7-point profile. And what this group did is went back and looked at the percentage time in range from the finger prick data and associated it with the complications that they saw in the DCCT. And as you can see here in figure A, the less time in range you have, and this is time between 70 and 180, between 3.9 and 10, the less time you have in range, the greater the frequency of retinopathy. And similarly, the less time in range, the greater the frequency of microalbuminuria in the DCCT participants. And for every 10% reduction in time in range between 3.9 and 10, there is a 64% increased risk of retinopathy and a 40% increased risk of microalbuminuria. So not only is time in range easier to understand and potentially easier to report, it's also associated with hard outcomes, and that's obviously very important. And it's one of the reasons why we're so keen on using HbA1c, because it's been associated with a hard, important clinical outcome for many years. Similarly, in type 2 diabetes, these are data from China, using continuous glucose monitoring in several thousand individuals. It's very clear that time in range is associated with both all-cause mortality and cardiovascular mortality. So over more than 10 years of follow-up, the lower your time in range here on the left, the greater your risk of dying. So you can see if your time in range is below 50, your cumulative survival is much less than for people with an HbA with a time in range greater than 85%. And the same is true if we look specifically at cardiovascular mortality in people with type 2 diabetes. So this is a large group of people over a long period of follow-up using continuous glucose monitoring to assess time in range at baseline with robust mortality data. But does it add anything over and above HbA1c? Well, several studies have reported this, but I'll show you one in particular. And this tells us that time in range is very closely associated with HbA1c. So this time in range, this time within the middle range, is very well correlated with HbA1c. And it may be that time in range isn't telling us anything particularly more useful than HbA1c, but because it's so much easier to measure and because it may be more understandable to people with diabetes, it may be a more accessible piece of information to use. So times in ranges are associated with hard outcomes in type 1 and type 2 diabetes. They give us complete glycemic information above, within, and below target. And there's a strong relationship with conventional biomarkers such as HbA1c and mean glucose, which gives us trust in them and means that they are very useful in terms of giving accessible data to people with diabetes. But, and there's always a but, there are some things that we should be aware of for times in ranges that are important to consider as it becomes a more mature biomarker. So the first thing to bear in mind is that not all times in range are the same. So these are data that my research fellow Pari Avari has published from my group, and they look at some paired times in range for people who were using finger prick glucose and continuous glucose monitoring at the same time. So we took time in range using the two separate technologies, but they are from the same people at the same time, so they are paired values. And we showed that there are some really quite significant differences between real-time continuous glucose monitoring and self-monitored blood glucose times in ranges. So we need to be very careful when we talk about time in range, and it's important to think that they're not always the same depending on how they were measured and which device they were using. These are Bland-Altman plots, and they tell you about the differences. So the differences in times in range between the two technologies were up to 25 or 30% for time in range, and they were, this is below range, they were up to 2 or 3% different for time below range, and that doesn't seem like very much. 3% time below 3.0 millimoles per litre, or 54 milligrams per deciliter, that's 45 minutes a day, which is a significant exposure to hypoglycemia. These are the same data, just looked at slightly differently, just to emphasize that if we look at the percentage times in ranges here on this bit of the table, and we look during the day and during the night, and we look at the differences between CGM and self-monitored blood glucose, you can see that there are highly significant differences in almost all of those times in ranges measured by different technologies. So it's important whenever we talk about time in range that we talk about how we derived that number. The other thing to think about is how much data is actually needed. So I said earlier that we could, if we wanted to, report time in range from just a single day. But that single day may be a very good day where things went well with somebody's diabetes self-management, or there may be a very difficult day where things were much more challenging and there was lots of high or low glucose. So how much data do we need for time in range to be representative of the overall data set for an individual or for a group? And the answer to that, slightly annoyingly, is it depends. So if we're looking at time in range between 3.9 and 10, you need around 2 weeks of continuous glucose monitoring data. If you're looking at time below range, it can take over 3 months for that data to be reliable. And of course, that's very similar to HbA1c. And in a low risk group, so a group that's not having much hypoglycemia, it can be even longer. The other thing to think about is how often are we seeing data? So if you have a continuous glucose monitor with glucose values every 5 minutes, that gives you 288 values every day, you can get reasonable amount of data very quickly. If you're using Flash, which has a third of the data, so Flash only reports glucose every 15 minutes, it takes twice as long for all of your values to converge. And if you're using self-monitored blood glucose, even with 7-point profiles, it may take even longer. So the answer to how much data is needed is as much as possible, but the longer, the better. And how do we measure? Well, I've said already that the accuracy of the device is important and may give different results. So whenever we talk about time in range, we need to talk about the device and the data duration. And which ranges do we report? So this comes back to the consensus statement that was published in Diabetes Care last year, and I'll show you some more data from that in a minute. But that tells us that we should be reporting 3 separate ranges very importantly. So the first is time below 3.0 millimoles per litre or 54 milligrams per deciliter, and that is the best discriminator of exposure to clinically important hypoglycemia, and that's so-called level 2 hypoglycemia. You might also look at time below 3.9, which is 70, but the really important one is time below 3.0. For time in range, we should look at 3.9 to 10, or 70 to 180 milligrams per deciliter, and that's the best discriminator of overall glucose, is most tightly associated with HbA1c, and is the best marker for overall associations with complications. And for time above range, we should look at time above 10 millimoles per litre, and that's best associated, that is the best discriminator of exposure to high glucose. So those are the three that you should bear in mind: 3.0, 3.9 to 10, and 10. So let's come back to that statement that I said earlier. HbA1c doesn't capture hypoglycemia or glucose variability. Well, I would argue that HbA1c actually is still a fantastic composite measure of HbA1c, of overall glucose, hypoglycemia, and glucose variability. So here are data from Earl Hirsch, taken from some Dexcom data that was published last year, and it shows the relationship between time in range, between HbA1c and time in range, between HbA1c and mean glucose, HbA1c and time above range, and HbA1c and time below range. And you can see that there's very close associations between HbA1c and time in range, mean glucose, and time above range, with a weaker association with hypoglycemia. If we look more closely at that hypoglycemia relationship, and these are data from my group that we published a couple of years ago, above an HbA1c of around 8, so this is HbA1c on the x-axis, and time below threshold here on the y-axis, and you can see here you've got time below 70 and you've got time below 54. And if we look at the solid line and the solid dots for people using self-monitored blood glucose, below an HbA1c of around 8, actually there's a linear association between HbA1c and hypoglycemia. And so that's true for both thresholds. And that's even true for people using real-time continuous glucose monitoring for time below 70, though for time below 54, hypoglycemia is essentially eradicated. So HbA1c may not be a fantastic marker overall for hypoglycemia, as you can see from this correlation coefficient and this scattergram. But for people with an HbA1c below around 7.5 to 8%, actually, there's a very clear association between HbA1c and hypoglycemia. And what about variability? Well, you don't need to look at all of these, but this is, again, data from one of my research fellows from a few years ago, Ahmed Al-Laboudi, who now works in Abu Dhabi, and he showed very nicely that HbA1c has a very tight association with almost all of these values, and almost all of these are markers of glucose variability. And you can see that for almost all of them, there is a very close association. Those are correlation coefficients, and the p-value for almost all of them is less than 0.01, suggesting that HbA1c is closely associated with almost all measures of variability. So back to time in range. So times in ranges can be understood by people with diabetes. They can discriminate exposure to high, normal, and low glucose. They're fantastically useful when HbA1c is unsuitable, and they've been associated with hard outcomes. But I would say HbA1c remains very important and still has a role. I've shown you that HbA1c is a fantastic composite marker that includes sensitivity to HbA1c, sensitivity to hypoglycemia, particularly if HbA1c is low. It tells us everything that we need to know about overall glucose, and it's sensitive to glucose variability in its association with all of those variability markers. It may not tell us clearly the relative contributions of hypoglycemia, overall glucose, and variability, but HbA1c is a standardized, internationally recognized, wholly ubiquitously available composite marker. And one of the things that slightly worries me about time in range is that we forget how good HbA1c is. Time in range is not standardized, and I've shown you that we need to be careful about thinking about the data duration and how we collected the data whenever we report time in ranges. And time in range is best with continuous glucose data, which may not always be available. The other thing is that HbA1c may require just as much time to stabilize as HbA1c does, particularly for time below range. So what do we look at when we look clinically in our clinics for time in range? So these are recommendations that were published in Diabetes Care last year, and this is the international consensus of what we should be looking at from continuous glucose data. So there are 10 points here, and I'll whiz through them very quickly. So we should be looking at the number of days that CGM is worn, and this recommends a minimum of 14 days, which agrees with what I said earlier about the amount of time you need for time in range, the central time in range, to be reported. We need at least 70% of data for those 2 weeks, and we should look at mean glucose, so that's a very simple one. We should look at the GMI, the glucose management indicator, which is an estimation of equivalent HbA1c. So it's just the same as HbA1c in terms of units, but it's not quite the same as an estimated HbA1c, so the name was changed. We should look at the percentage coefficient of variant, and the target is below 36. And then we should look at time above 250, time above 180, and below 250. So that's level 2 and level 1 hyperglycemia. We should look at time in range 3.9 to 10 or 70 to 180. And as I said earlier, we should be looking at time below as level 1 and level 2. And the really important one is the level 2 hypoglycemia. And whenever we look at the overall glucose profile, we should use the AGP. So I will just quickly whiz through the targets, and I'll show you an example AGP. So the targets that the same consensus gave us were that for type 1 and for type 2 diabetes, we should be aiming for greater than 70% time in range. So here, 70% time in range, which is equivalent to 16 hours, nearly 17 hours. And that is very close to an HbA1c equivalent of about 7%. In older or high risk people, that can be reduced to 50% time in range. We should be aiming for less than 4% below 70 and less than 1%, so less than 15 minutes below 70. That's a typo. Sorry, it is not a typo. Less than 1% in the high risk people below 70, and importantly, less than 1% below 54. Sorry, it's early. And for time above range, we should be aiming for less than 25% above 180, and in high risk people, less than 10% of time above 250. So what do we see when we look at an AGP report? So this is a classic AGP report from the Dexcom system, and I'll quickly talk you through it. So if we start at the top left, we get the average glucose, and this tells us, so this is over 14 days, and it tells us the time period. So 14 days of data should be reasonable to report. And let's just check, we've got over 70% of data, and yet we've got 95% of data. So this is nearly 14 days and is over 70%, so that's fine. We've got an average glucose of 192. And then this box here tells us those times in ranges in line with the consensus. So we've got 45% in range, 0.6 below 7, nothing at all below 54, which is excellent in terms of hypoglycemia risk, but we've got quite a bit of data above 180 and a bit of data above 250. The coefficient of variation, which remember should be less than 36, is less than 36, which is good. And the standard deviation of glucose, which doesn't have a target because it's dependent on the mean, is 58 milligrams per deciliter. We then get this lovely graph, and this is a standardized day from midnight through to midnight. And we get this orange line, which is the median of glucose. Remember, glucose in diabetes is almost never normally distributed, so there's almost always a left skew to our data. So we should report median glucose. So here is the median glucose for each time period for a standard day over the 2 weeks. And we then get the interquartile range here in blue, and we get the 90th and 10th centiles in this green dotted line. And we've got our target range for this person here in the shaded hatched area, which is 70 to 180. So this lets us look, and we could say that for this person, they're generally above target overnight. So they could have a little bit more treatment to bring them closer to target overnight. Breakfast time, they don't seem to have a great deviation in their glucose, but lunchtime, they frequently have a hyperglycemic excursion. So we might think about some additional treatment to cover their lunch, and then their evening meal seems to manage quite well, but overall they're above target. And then you see down here, each individual day, you get a mini graph, so you can see if there are any particular days. So when you're talking to them, you can tell them about their overall profile, and you can point out that on the 12th of June 2020, they had glucose that was really fantastic and mostly in target. So you can then talk about that particular day, or you can talk about the challenging days, or just talk about the general profile. So in conclusion, times in ranges. In conclusion, a comprehensive assessment of glucose self-management should include an overall measure of glucose, and that could be HbA1c or mean glucose, or time in range 3.9 to 10. A measure of hypoglycemia, and that should be time below 54 or time below 3 as the ideal range, and a measure of glucose variability. But don't forget that HbA1c remains a pretty good composite of all of those things and is ubiquitous. The best measure of overall glucose is the one that you already have. So there's no reason to do additional new things unless it tells you something new, or unless there are significant limitations, for example, to HbA1c. And all measures, so all of the things that I talked about, are good at detecting change. So if you've historically measured one thing, be consistent and continue to measure that one thing, and you'll know the change in glucose status for your patient. It's important to be consistent and only change really if there's a good reason to. So times in ranges are fantastic. They're very useful tools, but they're very useful tools in addition to what you already do. And at the moment, they're not replacing HbA1c. But if we see a standardized way to measure time in range, and if we see better access internationally across the world to continuous glucose data, we might see a gradual shift towards reporting those 3 times in ranges above, within, and below range.
Thank you very much, Nick, for that very comprehensive lecture in an area which is emerging in the diabetes world and relatively new for this part of the world, simply because of the cost issue that we don't have the continuous CGMS units. Just to get the ball rolling, and we have a couple of questions for you. What would be the cost for 14-day CGMS measurement in the UK in your clinic? Just to see how viable it is for us to start on these things. What would be the cost of a system for 14 days to get the data?
So I think the best value way to do that, and we don't have this actually. Do you have the Freestyle Libre Pro device?
Yeah, not at the moment. Even that is not available.
Okay.
So which costs about $80, I know, for a patch. So which is not within the reach of many Sri Lankans, and for that matter, a lot of people in this part of the world. But the meter is quite reasonable, but the patch is expensive.
Yeah, no, absolutely. But I think that remains the lowest cost way to report 2 weeks of time in range. You could also use the Dexcom G6 Pro, which is likely to be slightly more expensive, though perhaps not hugely different. So that may be around $100. But as you say, they are. I mean, they're beyond that cost is beyond most people here as well. It remains an expensive way to measure glucose. So if you're able to do 7-point profiles with self-monitored blood glucose, that may be your cheapest way to do it. And if someone can do 2 weeks of 7-point profiles, you may well get some useful benchmark data.
Yeah, thank you, Nick. So you have a question from the audience, the virtual audience. The question number 1, somebody wants to know how to define time in range for pregnant women with type 1 diabetes. I think it was in that paper 63 to 140, if I remember right. But do you all follow the same ranges, or you have something different?
That's a very good question, and sorry, I didn't cover the concept data. So as you're all familiar, concept is a randomized controlled trial of continuous glucose monitoring and self-monitoring in pregnant women with type 1 diabetes, and it showed beautifully that using tight targets, as you said, of 63 to 140 as time in range in women with type 1 diabetes reduced materno-fetal outcomes of admission to neonatal intensive care, large for gestational age babies, and neonatal hypoglycemia. So it's very clinically effective. I don't do any of the type 1 pregnancy work, but my colleagues use the same targets as the concept study because those are the evidence-based targets. And we're very fortunate at the moment in England as all pregnant women with type 1 diabetes can now have Dexcom G6 real-time continuous glucose monitoring. So that's hugely fortunate for us, and hopefully that will show both clinical and cost effectiveness in the real world.
Thank you, Nick.
There's another question, Nick, from the virtual audience. If we check the fasting blood sugar levels, a level above 125 to 130, would it be considered as being, as time in range? So, I mean, indirectly what the person is asking must be, whether it overestimates the time in range, values like these?
Yeah, it's a very good question, isn't it? Because that obviously is in range in terms of 70 to 180, but if we had a fasting glucose of 125 to 130 or obviously even higher, that would not be a single normal fasting glucose. And this is one of the problems with time in range, is that if you report it from a very small data set, you don't get a good representation that correlates or is associated with somebody's diabetes status or their diabetes risk. So if you want to do fasting values and you want to use them to guide treatment or to diagnose diabetes, you need to stick to the conventional reference ranges for that. If you have a large data set and you have some post-meal values and some later non-fasting values, that will be much more useful in terms of thinking of time in range. So I wouldn't use time in range for fasting values alone because it hasn't been validated to do that.
Thank you, Nick. I think the question, have you ever tried food diaries being combined with this data, the food patterns? Because that's this same question that came to my mind. Some people in this part of the world has a very high carb, content for their dinner. They have a light lunch, a light breakfast, and a heavy dinner. So those people might have a slightly high fasting, but when you do the time in range, probably they might fit in during the course of the day. It might be low in a certain category of patients. So do you have any experience with the food diaries and your data being compared?
Yeah, absolutely. So I don't know what your patients are like. My patients are generally not great at filling out food diaries because they don't tend to always want to tell us exactly what they did eat, or they forget, or they do it inaccurately. So they're not always fantastically filled out. However, the nice thing about using the AGP, so that lovely profile of 24-hour glucose, is that if they do have that sort of pattern of a light breakfast, light lunch, and a carbohydrate heavy evening meal, then we would see that in their AGP. So we'd see a flat profile for breakfast, a flat profile for their lunch, and then we'd see this big spike in the evening. And then we can talk to people about what they usually eat. Most people have a fairly small repertoire of meals. So most people have a very similar breakfast every day, similar lunch every day, and have maybe 4 or 5 evening meals that they will commonly have. So it's generally quite easy to discuss which ones of those are the difficult meals to manage and which ones of those cause significant glucose elevations, and then think about how we might change either their treatment or their diet. Though we try not to change diet because people have their preferences and tend to stick with those. But yeah, absolutely. Having time in range alongside food and exercise and menstrual cycle and alcohol and stress and all of the other things that can affect glucose is really important in all diabetes. As you all know, none of these things are sufficient on their own.
Thank you, Nick. In the interest of time, I think we have to stop this session now. And thank you very much for that very interesting lecture and taking your time off very early in the day in UK. Thank you very much.
That's my pleasure.
On,
Take care. Have a
on
lovely day.
behalf of SAFIS, I would like to thank you for joining us today. Thank you very much, Nick.
Thank you very much, everyone.